Hello, everyone, and welcome to Carolina Breast Friends YouTube channel. We are glad that you're here. Tonight, we have a very informative session that we'll be talking specifically about follow-up screening after breast cancer treatment.
Thank you so much for having me. Yeah, it's a real honor and privilege to be back. I first was connected with Carolina Breast Friends about this time last year. I did a lecture about a high-risk population for developing breast cancer and how we image these women specifically. And so now I'm really happy to be back, thrilled to be back to kind of take the next step. And, obviously a lot of our audience are survivors, thrivers, people who have already received treatment. And so this lecture is going to be, whereas it'll be about following up, the follow-up imaging after treatment, whereas last year we were kind of talking about the imaging in the high-risk population, more about initially establishing that diagnosis. So I think this is a great sequence of a lecture, and really happy to be here. And a kind of a great follow-up from October and being at Pink Boots at the lawn, on the lawn. It was really great. We were able to meet a lot of the Pink House staff and the board. And so this is great. And just a little bit about myself. So relatively new to Charlotte. I've been here for a little over 2 years, spent all of those years with Mecklenburg Radiology Associates. So we're a large specialized private practice, practices radiology, and very subspecialized. My subspecialty is breast imaging. So that is what I did my fellowship in. I did my fellowship training at Wake Forest. And so happy to be here and happy to get started. We can take questions at the end. I'll open it up to a Q&A, or like Harry said, please feel free to chime in the chat section. So we'll go ahead and get started. All right, so first I wanted to go over some objectives, just real briefly. So one of the first things I wanted to touch on was just the difference between a diagnostic mammogram and a screening mammogram, and when each is appropriate. They have a lot in common, but there are some differences. Oftentimes it can be confusing to patients, and even sometimes some providers. So there, some subtle differences about them, and then when what their role is following a treatment of breast cancer. So the other is to discuss the follow-up necessary for different types of operative treatments. So of course we have breast conservation therapy or a lumpectomy, and then there's also mastectomy, the complete removal of breast tissue, which sometimes can be just one breast or both breasts. So how that changes. And then options for patients who have had that mastectomy, who may or may not have had reconstruction, and just what follow-up looks like or imaging options are for that. And then just kind of giving a glimpse into what we as radiologists are looking at on our images when we're looking at a patient who has been treated for breast cancer. What are the things that we're kind of tuned into? What may be a red flag for something that may be needs further evaluation, something that could be concerning for a recurrence, or just routine findings that happen after a surgery or things like radiation. And then I want to talk about breast MRI, a really important modality or type of imaging that we have in radiology, and when it's appropriate, and kind of the pros and cons of breast MRI. And then just kind of touch about how patients who've had chemotherapy or radiation, what that looks like to us when we take our imaging, how that can affect the breast, not only just from a physical exam standpoint, but then also how we see it on our imaging, and what we're looking for. And then the other topic is we have other things in radiology, not just breast imaging. Unfortunately, breast cancer can affect the entire body at times when it spreads, metastatic disease. And so we have other imaging that we can do to evaluate for that, or assess responses. So we'll touch on that towards the end. All right. So just to begin with, just kind of a brief overview of breast surgery. So I am not a breast surgeon. Breast surgeons are highly specialized surgeons, just like we are highly specialized radiologists. But that we all make up the breast care team. But it's really important for us, obviously, to understand the surgical options and how those appear on imaging. So just want to go over this because I think it'll really lead into the lecture. So first of all, we have a lumpectomy. So this is breast conservation therapy. So what lumpectomy is it is the surgical removal of the cancer cells that have a normal amount of tissue around the cancer. So the goal is to remove the cancer as well as a small amount of normal tissue surrounding it, while, of course, removing all of the cancer, but leaving the breast enough intact that there's still a desired cosmetic result, that the entire breast does not need to be removed. So we'll talk about how a lumpectomy looks on imaging, and then also a specific follow-up for a lumpectomy. And then for mastectomy, so this is when all of the breast tissue is removed. This, of course, can be unilateral, bilateral, so that's a single or a double. So unfortunately, cancer can affect both breasts at times, in which case that could lead to needing a double mastectomy. Sometimes patients, if they only have cancer in one breast, then we'll do a single mastectomy. Of course, there are other options. Patients can choose, even if they only have breast cancer in one breast, to do a prophylactic mastectomy, which just means that we're taking the other breast will be removed, even though there's no cancer in that breast, just to reduce the chance of developing cancer in that breast in the future. And the difference between the two, lumpectomy and mastectomy, aside from patient choice, is oftentimes just the extent of disease that's in the breast. So whether it's, say, under 5 centimeters of disease or greater than 5 centimeters, whether it affects multiple quadrants in the breast, different areas in the breast, it's basically, it comes down to your treatment team's decision of what we would recommend based on, do we think that we can get the cancer removed from the breast safely and effectively with a lumpectomy to still have enough of the breast tissue left to have what oftentimes is a desired cosmetic result. So that's really the difference there. And then beyond a mastectomy, the skin or nipple sparing. So when we do a skin sparing mastectomy, that's going to be where the nipple will be removed along with the breast tissue itself, but the skin will remain. Whereas a nipple sparing, the breast tissue is removed, but there's still the nipple and the skin, but all the breast tissue is removed. And then when we have mastectomy with reconstruction, it's basically, so again, the mastectomy is removing all of the breast tissue. And then the reconstruction, we have things like flaps that surgeons can do, where they'll take, it's essentially a graft of a different part of the body, whether it's from the abdomen or the back. And it's the patient's own tissue that then helps to reconstruct the breast, but there's still no breast tissue left in that reconstructed breast. And an implant, as we can see in just the pictures, this is, I don't know if you can see my mouse, but this is what a mammogram looks like when patients have implants. This is behind the muscle here. And so this allows for more of a normal shaped breast after mastectomy. But again, the main take home is lumpectomy, there's still breast tissue left. Mastectomy, there's no breast tissue that remains. So oh yeah.
In the picture with the implant, had this patient had a mastectomy?
No.
Okay,
sorry. This patient has not had a mastectomy. If you can see my pointer, this kind of bright tissue right here, this is breast tissue, as you can see. So this patient is a non-specific patient, but certainly could have had a lumpectomy with reconstruction, or this likely is an intact breast. I just wanted to show a picture of an implant and how that comes across on mammogram. But this patient, we definitely can see has normal intact breast tissue. So this is not a mastectomy breast.
Okay, thank you.
Of course. And so then we go into what I specialize in, so breast imaging. So these are what we have available to us to evaluate the breast, to determine if there's anything suspicious for breast cancer. And we get to, some of these are more, standard. I mean, mammogram being standard, it's very rare that we wouldn't do a mammogram on a patient. And so this is mammogram and ultrasound are the two main imaging modalities that we utilize. Mammogram is essentially X-rays that we use, and here is the two views that we do to evaluate the breast tissue. We'll talk a little bit more about a mammogram. Here's an ultrasound. Ultrasound uses sound and the reverberations of sound to show breast tissue. Ultrasound is really good for looking at masses. It does a really good job of differentiating a solid mass versus a mass that's a cyst, maybe filled with water or fluid. And it also does a really good job of looking further at dense breast tissue, which mammogram sometimes can be a challenge evaluating dense breast tissue. And then MRI, so it uses magnetic frequencies to take another look at breast tissue. What's really helpful with MRI is that we give contrast, which goes in through the veins, and what we look for is abnormal enhancement. So contrast would go to an area like cancer and light up more like a light bulb, more so than background breast tissue, just because of how cellular and vascular cancer is. It's more vascular typically than background tissue. So that's more blood flow is going to go there, and it enhances more. So that's what we look for on MRI. And I've got a slide later. We'll talk a little bit more about that. So then as we go to screening versus diagnostic, just a really important differentiation. So screening mammograms are what we recommend for either women who have an increased risk of breast cancer, typically between 20 to 25% lifetime risk of developing breast cancer. So they can start before the age of 40. But for people who are of normal lifetime risk of developing breast cancer, current recommendations are to start at age 40. So it's, for asymptomatic patients without specific follow-up needed. And then diagnostic mammogram is usually for patients who are experiencing a specific symptom, have a history of breast cancer. They may have an abnormal screening mammogram. So if we see something abnormal on screening, then we would have that patient come back for a diagnostic or a callback mammogram. Or if there's a specific finding that we're following that we've seen previously, and we want to have that patient come back. So the main difference are, well, I guess I'll start with what they have actually in common, is that they are the exact same image quality when we do the standard views of each breast. So here are the standard views of each breast. So there's CC, it stands for craniocaudal, which just means that the image receptors are coming from the top and from the bottom. And so that produces this image. And then we have MLO, stands for medial lateral oblique. So medial coming from this way, lateral coming from that way, and oblique just because it's not straight up, or it's not side to side, it's kind of obliqued. So these are what we do for every patient that has a full mammogram, whether it's screening or diagnostic. And there's no diagnostic isn't special when it comes to these four images that we do. They're the exact same. What the difference is is that if we need additional views to be done, understanding that the majority of people who are tuned in have had diagnostic mammograms because there have been abnormal findings on that mammogram. It's when you come back and we do specialized pictures. Those can be magnification views where we're looking at calcifications, or we're putting compression in a really specific area on the breast because we're worried there may be a mass there. And then we can also do ultrasound during that time. So all of that is done concurrently at the time of your diagnostic mammogram. Whereas screening, if we see something that's concerning, well, then you would need another appointment to come back at that time. So it's really that you would need to return for the additional imaging, as opposed to a diagnostic. It's performed during that appointment. And so the radiologist, when you have your screening mammogram done, you leave as soon as that's done, and the radiologist looks at it, sometime shortly, but it's not immediate, and the results are sent to the doctor. Whereas the diagnostic mammogram, you get real-time report or real-time conclusion, and so you have those results that day, and so that's really the difference. And so what we'll do next is we'll kind of talk about when it's appropriate to have that screening and when it's appropriate to have the diagnostic, because again, they're the exact same quality. It's just gives us that opportunity to do additional exams with the diagnostic without you having to return.
And there's a question in the chat regarding 3D mammography. Are all mammograms now 3D, or is it based only on the type of equipment the medical facility has?
So at our practice, 100% of the mammograms are performed with 3D or tomosynthesis. It's really been shown to be vastly superior, not only in cancer detection, but also reducing the amount of callbacks that we recommend. So it is a better study. So we in most radiology practices or hospital systems should be at 100% 3D, and if they're not, that really is their goal, because it is that much more superior. Every once in a while, sometimes we'll run into patients who need to do TD. Maybe it's an insurance issue, it's an out-of-pocket expense issue. But as much as we can and work with the patient, our goal is to do 100% 3D. Now, there are some pictures that we do that are not 3D. For instance, like a magnification view is not 3D. But as far as the routine imaging, it's always tomosynthesis for us. All right. So getting to the next slide. Thank you for the question, by the way. It's an important one. So going into the imaging follow-up after a lumpectomy. So again, we spoke about what a lumpectomy is. In a sense, it's taking a lump of breast tissue instead of the entirety of the breast tissue out. And so what that causes is there's actually it changes the appearance of the breast quite a bit. So after surgery, there can be scarring that's seen in the breast. Sometimes patients will have radiation. Radiation can cause changes to the breast, and we'll talk about what radiation does specifically a little later. But the point is that when you have that surgery, as anyone could imagine, I mean, it's like if you were to get cut or have a bruise or have an injury, scars can form. Sometimes it can be deformed compared to what it was prior. So the breast looks really different. And so what we recommend then is that for the first 2 years, and this sometimes can vary, but typically this is a standard, and it's what we do for our practice, is that the first 2 years after a lumpectomy, you come in for a diagnostic mammogram. So you will have that option to see a radiologist. And we do, just by default, do additional images. We do magnification views of the lumpectomy site. And magnification views are just what you would imagine. It's just, we have a special mammogram that it just allows us to see, magnify some of the portions of the breast. And what we're looking for, calcifications. So calcifications are really common in the breast. They can be many number of things, but they can also be one of the first signs that we have of cancer. So it's really important that we evaluate these. The other thing is that calcifications are really often not cancerous, they're benign, and we can see calcifications after surgery that can happen essentially after damage is done to the breast tissue from just the surgery. So these magnification views are really important for us to take a special look. And then if there's anything additional that we see, we have other views, other ultrasound that we can perform. And really what we're doing for these first 2 years, at least the way I think about it, is that first year, we're getting a new baseline, a new picture of what the breast looks like following surgery, following radiation, so that we can compare it to exams in the future. The other thing we're looking for is was there any cancer that wasn't included in the lumpectomy? Maybe it was in a different side of the breast. Maybe it was surrounding the lumpectomy. So we're really looking for, were there any sites of cancer that weren't removed with the surgery? So that's really what we're looking for. And then, of course, we'll look at the other breast too to make sure nothing's developed there. The second year, and again, this is how I think about it, then we start looking. So we've got a comparison, and then we're starting to look at the lumpectomy site itself. So where the scar is, are there any signs of recurrence? So that's when I really kind of hone in on, are there new calcifications there? Is there a new mass there? Because we've had a year to compare it to, and it's also been 2 years since the treatment. So then I start thinking a little bit more about recurrence. And then if after those 2 years, everything looks good, that's when we recommend going back to screening mammogram. So again, the same exact image quality. We're doing 3D, we're doing tomosynthesis. We get a great look at the breast. But it's just that there won't be results that are returned that day. And if there is additional imaging, it's just an additional appointment. But again, there's not that one is more superior than the other in terms of image quality. And of course, in addition to this imaging follow-up, then there's clinical observation by your oncologist, your surgeon. They will be doing physical exams. And if they see anything suspicious, then that's when we would do a diagnostic mammogram, because then there'd be a symptom. And then real quick, here's what we have, what we often look at with a lumpectomy. So here are magnification views. It's hard to really see on this presentation, but this is where we're looking for calcifications. And what we can see here, and kind of what I've outlined here, is what we expect to see. So these are normal findings after lumpectomy. And we can kind of see here, this is kind of some indentation, some puckering here, and kind of see it here. So this is kind of some scarring, a little bit of a deformity of the skin that kind of tugs in, it pulls in like a scar would. It kind of, pulls the tissue in, and we get to see a little bit of distortion here, which I just think of the tissue kind of being pulled in by a scar. And so we're looking for any calcifications or any new masses there. Here's another area. We see surgical clips. These are these bright things that are around this big, bright scar right here. So this is what we expect to see. Again, some skin thickening here and some kind of puckering indentation here. So these are a lot of things that we see. So our job is to differentiate these things that we expect to see from the more concerning, suspicious things where maybe we would need to do another biopsy or an ultrasound to investigate further. And so this is just a quick kind of slide. I've talked a lot about calcifications. They're a really important part of our job, and an important part of early detection of breast cancer. So I won't spend too much time because it's kind of getting into the nitty-gritty of our field, but these are calcifications that we often see that are benign. So a lot of these we can see in things like post-surgical change, what I kind of call bruising or trauma to the breast tissue, which is called fat necrosis. It's just what happens when fatty tissue, which makes up a large portion of breast tissue, experiences trauma, and it can turn into calcification. and we have to differentiate those between these. As you can see, suspicious morphology, and these are some of the calcifications that we would end up biopsying to make sure that to evaluate further to make sure that cancer hasn't recurred or that cancer wasn't excluded from the surgical site. Oftentimes for patients, I just say thank you for being patient with us, just because it's a pretty subtle difference, and so a lot of times we do a lot of different pictures, a lot of minor adjustments, just because we want to do our best for our patients and make sure that we're not doing too many unnecessary biopsies, but also not sending patients out the door if there may be something concerning. So I always make sure to thank you all for being so patient, understanding as we go through our process. So now that we're moving on from a lumpectomy, here we have the follow-up after mastectomy, which is really different from a lumpectomy, because just the essence of a mastectomy is that there is essentially no breast tissue left, especially if there is so a simple mastectomy. Again, skin, nipple, breast tissue is removed. There's really no breast tissue left. Especially some mastectomies can go down to even the chest wall, with right down to the muscle. So two reasons we don't do routine follow-up on for mastectomy patients is, one, there's really no breast tissue left in order to do a mammogram. A mammogram, of course, that compression that happens with the breast tissue, there's no breast tissue there, then it makes it really difficult to even perform a mammogram. But the other is that there's just the data is not there that says that doing a mammogram shows any benefit in detecting a recurrent cancer, just because the breast tissue is so minimal. And also, if there is to be something like recurrence, maybe it's in the handful of cells from the breast that are remaining. Oftentimes, those are first found on physical exam. And so that's why clinical observation is the most important thing for a mastectomy. So you'll have, your oncologist, your surgeon, even your primary care doctor will be doing exams. And at the first sign of something that's different, something new, something that's growing, something that's changing, that's when you'd come back to see us in radiology. And again, mammogram is really challenging for a patient who has had a mastectomy, but that's where we start with ultrasound. Ultrasound is a great tool that we have. So then we could see if there is anything concerning, like a mass present. And if there is, then we can take it to ultrasound if we're concerned. And then the other option that we have is an MRI, which is what we have here. So Carrie, kind of your question earlier. So this is actually a patient who, this shows on this MRI, a patient who does have breast tissue in this right breast, but a mastectomy on the left side. Must be a flap, because we can see there's none of this bright glandular tissue here, but this is fatty tissue here. So this is likely from a flap that has some grafted fat from either the abdomen or another part of the torso. And this just shows, this also is probably a graft, because all we're seeing here are blood vessels, and then implants here. So of course, when there's a graft, the blood vessels need to remain intact in order to keep that tissue alive. And that's why it's a very intricate and delicate surgery, oftentimes done with a microscope, to make sure that those blood vessels remain intact. So an MRI and ultrasound are really the two most common modalities that we use. And so probably the one caveat is when we do the nipple sparing mastectomy, because when you keep the skin and the nipple, there has to be some tissue that's left. It's a very small amount of tissue, but if you take all the tissue out, then then the skin and the nipple won't be able to survive. It needs blood vessels, just as I showed in this picture. This is just from a graft, but so there is a really small amount available or that remains. What your surgeon does is, if there is nipple sparing, they take a little shaving of or a little kind of representative sampling from right behind the nipple, send it off to pathology. They look at it under a microscope, make sure that that area is clear of cancer before the surgery concludes, to make sure that it is safe to keep that nipple intact. But there is a really small amount there. But still, the general consensus is that physical exam is the best way to follow up a patient with a mastectomy. And again, if there is a finding, something concerning on physical exam, then you come to radiology, ultrasound, MRI, then we work it up. Typically not with mammogram again. Even though you can do a mammogram if you've had flap reconstruction or implants, it's still just not what we would start with typically.
So we do have a question
Yes.
in that. Is tissue left over after skin sparing? And go ahead.
Yes. So yes, in skin sparing, it still is, but a very, very minimal amount. I'm not a surgeon, but I would imagine it's it's an incredibly thin amount. It's enough in order to keep that skin perfused with blood. So again, it's not a significant amount. Gosh, I don't know what the numbers are, but it's probably less than 1% of the breast tissue remains. I'm sure it's less than that. And so it's not enough, again, to have a mammogram. But so that's again why we do physical exam. But there is a small amount, just because it has to remain in order to perfuse the skin. And there's even a little bit more for nipple sparing, just because again, you have to keep that nipple in the areola complex perfused. So there is a small amount.
And I wanted to ask about the chest wall, in just thinking through, understanding that the minimal amount of tissue left under the nipple or up under the skin may present at the very top and be able to be felt on physical exam, on a clinical exam. But the chest wall, is that something that can be shown in screening in either MRI or ultrasound?
Yes. Yeah. Chest wall. I mean, that's a great question. So just chest wall, particularly, could be a little bit more challenging to come up on physical exam. And depending on the surgery, whether it was a radical mastectomy, which does go down to the muscle layer, some cells, portions of the breast tissue could remain, but an MRI will show that. So here is the muscle of the chest wall that we can certainly see. It is a little bit more challenging at times with implants. Implants can obscure portions of the breast tissue. So you can see they kind of sit here along the chest wall. So here's the heart and the lungs, just a kind of quick orientation. So this is the kind of in the chest. And here are the muscles, your ribs and your muscles of the chest wall. And so the implants sit right on top of it. So implants at times can cause a little bit of a challenge for us, as they can obscure masses that can be right up under the chest wall. But MRI is really, really good for including the entire field of the breast. Ultrasound ultrasound's a great tool, like I've mentioned before. Sometimes it can be a little more challenging, especially if a patient has a large breast or a large reconstructed breast, to get all the way down to that chest wall. But ultrasound can certainly aid in that. And we're really good at finding those, even if they're on the chest wall, and still being able to appropriately biopsy them safely. So it's a great question. It does provide a little bit more of a challenge. And this is for anyone who hasn't had surgery. If a patient has something develop on the chest wall, say a young patient who hasn't started screening yet, those can be a little bit more scary because it would take a while for that patient or the patient's doctor to feel it if it's buried deep down in the breast tissue. But yes, we have a lot of good tools to be able to still visualize that. So great question. And then just another kind of important caveat before we move along is for patients who have had a single mastectomy, so kind of like this patient right here. It's what we do is we do screening mammogram for the intact breast. So just like we don't do follow-up of the mastectomy, if a patient still has an intact breast that is asymptomatic and we're not following up anything further, then they still can have a screening mammogram of the normal intact breast every year. We is the recommendation. All right, so getting into breast MRI. Breast MRI is an incredible tool that we have, but it's kind of one of those, funny Superman, Spider-Man, with great power comes great responsibility sort of thing, where it's so good at detecting breast cancer, but it's also really good at detecting things that aren't breast cancer, a lot of the benign things that we wish that we didn't see, or it didn't draw attention to us, because it can lead to a lot of unnecessary workups, a lot of unnecessary biopsies. So it definitely takes a specialized radiologist, someone who's done breast imaging, to be able to interpret them, just because they are challenging. So that's kind of what I have here: pros and cons. Very sensitive. I think of it in the way of kind of have this fishnet here. So sensitive just means that it's gonna catch. It's likely to let cancer fall through the net. It's got very small holes in the net. Cancer is unlikely to fall through, but because the holes are so small, benign things, not cancerous things, are not going to go through the net. They're going to stay in the net. We're going to catch those too. So the good and the bad is that it catches a lot. It's small holes in that net, but it also can lead to a lot of additional workup that ultimately can come back not cancerous or not concerning. So we have to be really careful when we recommend it, and for the patients that we do it for. That's why we don't do it on every single patient. The patients that we recommend breast MRI and who get maybe more routine breast MRIs, so first and foremost are high-risk patients. The data has shown that for high-risk patients, there is a benefit of doing breast MRI in addition to mammogram. Typically that's done alternating every 6 months. So you'd still have a mammogram every year and a breast MRI every year, but they alternate every 6 months. So that every 6 months, we're getting a look at the breast tissue, whether it's through an MRI or a mammogram. And then so evaluating breast cancer, maybe some people at this lecture have had those when they got their initial diagnosis of breast cancer. So that's MRI can be very good at evaluating the extent of disease, meaning how much of a distance does it cover in the breast? How much of the breast is it involving? And that can really dictate, are you a lumpectomy candidate, or is this meaning that we're probably moving to mastectomy because it's unlikely that we can remove all of the cancer with a lumpectomy with retaining a cosmetic outcome that's acceptable. And so that's a really common reason why we would do a breast MRI. Also to evaluate treatment response. So we'll talk about patients who get chemotherapy prior to surgery, which the intent is to really shrink the cancer prior to surgery. And so we do breast MRI to look to see how has that chemotherapy or hormone therapy affected that tumor, and is it now smaller? And so that's an important thing. Mastectomy patient, just like we just spoke about, can be a really great tool there. You can also, one of the asides it's the main tool that we use to evaluate if silicone implants are still intact. So that's just another reason why we can do breast MRI if there's a suspicion that a silicone implant has ruptured. And here are just some pictures. So here is an area of a mass that's brighter than the rest. Again, it's more vascular, more cellular. So blood flow goes to it more so than the background tissue. So that stands out. Here's another area right here that would be cancer. Kind of looks irregular, brighter than the background. And then these just generally, of course, this is only one slice. This would be something that would likely be amenable to lumpectomy. So you take out this mass here, and then the surgeon would take out a little rim of healthy tissue around. And then, of course, after the surgery, they look at it under a microscope and make sure that these margins of the healthy tissue are all not cancerous and that there's been a good negative margin there. This is a picture of cancer that extends throughout much of the outer aspect of the breast. This is the outer aspect of the breast. So this is certainly more than 5 centimeters of disease, affects a large portion of the breast. This would be something that would need to ultimately have a mastectomy. So this is just kind of showing what we see on MRI here. And then so outside of our surgical options, these are the other components of treating breast cancer. So, we've got chemotherapy, radiation therapy, hormone therapy, where we have medical oncologists and radiation oncologists that, of course, form up this breast cancer team. And so what the intent of these treatment options are. So we talked about kind of getting therapy or treatment before surgery. It can reduce the size of the cancer prior to surgery, which we'll talk about the benefits of that. It can also, it helps aid in making sure that all of the cancer cells are treated, not just the ones that were removed surgically. So if there was any cancer that had been left behind, maybe it had affected the chest wall, maybe there was a microscopic amount that was left outside of the lumpectomy surgical site. These things can also be used for cancer that has spread. It's spread beyond the breast tissue. Maybe it's in the lymph node, maybe it's even more distant and in the lungs or the bones. So we have your treatment team has these available for that as well. And of course, treats for recurrence. And they also reduce the risk of that cancer recurrence doing these in addition to surgery. So these are, again, all these options, and we'll discuss how these options change breast imaging as well. So this is what I've been alluding to a couple of times. It's called neoadjuvant chemotherapy. It's basically just a word that means, so it's adjuvant. So it's something that aids. It's done in addition to surgery, but neo meaning before surgery. So the goal is to receive chemotherapy or hormone targeted therapy prior to surgery. So here's a picture. This is a mammogram with the arrows showing these are large cancerous masses here. And then on ultrasound, these are abnormal lymph nodes, thickened lymph nodes that are certainly suspicious, would be consistent with metastatic disease to the lymph nodes. And this is NAC, neoadjuvant chemotherapy. You can see that the tumor has shrunk. Clearly not seeing the tumors here. And this is a normal lymph node. It's now a normal appearing lymph node. This lymph node would still be taken out with surgery, but it's now completely shrunken down to what looks like a normal lymph node. And so really the reasons that this can be done is that it makes a less, it basically aids the surgeon to have a less extensive operation that can be done, especially if the patient is still wants to preserve or conserve some of their breast. It can also just help the recovery if the masses are smaller. Can also help shrink the lymph nodes, and so it's just a really helpful part of the treatment and how we end up seeing it on our end. And then after this, the pathologist still checks the breast tissue to make sure that the cancer has actually been treated. You can see the cells look different under a microscope if they've been treated or not. So again, a helpful thing. And another benefit of this is that when we get to see, we know that this cancer is responding to chemotherapy. So that's really helpful for the treatment team to know, even after surgery, that, hey, this cancer is responding well to this treatment regimen. And so beyond neoadjuvant, many patients receive chemotherapy following surgery, and there's really no, the data shows that it has generally the same effectiveness, whether it's before surgery or after surgery. It can just basically change the patient's surgical outcomes or just help aid the surgery. So just kind of an important thing to be aware of there, and how we see chemotherapy affect the breast. And then here is radiation. So another thing in addition to surgery that can treat cancer, and how we get to see it. So radiation can really, it can cause quite extensive changes to the breast. It can cause skin thickening. We can see skin thickening here. This is a normal breast, normal skin, really super thin. And here, very thickened, can cause swelling. What happens is can cause engorgement of the lymphatics. And so there can actually be edema or swelling in the breast tissue. For anyone who's had radiation, I mean, it can be very warm, swollen, and painful after having radiation. And so you can see just the stark difference between this breast that's been radiated versus the normal breast. And so on ultrasounds, even we could see the black lines that we see here, this is swelling, this is fluid in the tissue, and this is thickened skin right here. So again, this is all just to say that there are a lot of changes that go on in the breast, a treated breast, whether it's through chemotherapy, radiation, surgery. And so that's why we keep a really close eye on it, especially for those first 2 years following treatment. And then just the things that we look for, just to make sure that, we know what is expected after these, and what is maybe raising a red flag for recurrence or additional sites of cancer. And again, just the way that radiation works, as you can see here, so they're high energy particles that destroy cancer, and that because cancer cells are just they're just much more susceptible to the effects of radiation, because they have a lot more turnover than regular cells. So they're much more the activity of the cells are just so much more active that radiation affects them more than regular cells, and that's kind of their mechanism of action. So this is our last slide. So these are additional imaging options that we have. So metastatic disease, unfortunately, describes disease that is spread beyond the breast. So disease that goes to the lymph node. Lymph node is the vast majority of where cancer spreads to first. If it spreads outside of the breast, something like 99% of cancer would spread to the lymph nodes first. And so that is why, if we do a biopsy or we have any suspicion of cancer, we will always look in the lymph nodes. Well, not always, but the majority of the time, we will look for the lymph nodes first to see if those are abnormal, to do a biopsy there. But beyond that, these are our options to look for distant spread. So breast cancer specifically, so the most common places for breast cancer to spread, so bone and lungs are the two most common. They can also go to the other lymph nodes under the arm, liver, and the brain, and other ways. So if there's concern for spread, we could get staging studies. So we get CAT scan, which is basically just a really specialized X-ray machine that puts out a 3D model of the body. So here's a CAT scan right through the abdomen. And so we would get pictures of the chest, the abdomen, the pelvis to make sure that there are no lung nodules or liver nodules or bony lesions. And if they are, then we have other ways to follow that up or to further assess if it is in fact spread disease. We can always do a biopsy. Here are some other options. So a bone scan is an interesting study. Here we can see that this is a bone scan. It's a nuclear medicine test that basically injects radioactive material into a body. And what it does is the radioactive material shows up on a camera, and the radioactive material goes to areas of high bone growth and turnover, which if there is a cancer, a tumor in bone, like I said, it's hypercellular, turns over a lot. So it's going to have a brighter area on this. This is a normal bone scan, but for instance, this shows a normal area, but you can see this dark area right here. This is from, it's probably arthritis here, but it would show up there more dark. And so we would know that can be concerning. So that's really good for looking for any sort of spread to the bone. And then a PET CT. So this is a really interesting nuclear medicine study where radioactive material is bound to essentially sugar, because again, cancer tumors, they are really active. So they eat and require more sugar than elsewhere in the body. So the bright radioactive material kind of floods into those tumors, and they show up as brighter than background. So this is a really good way to evaluate for, is there any cancer elsewhere in the body? And an even cooler study that we've got that's coming now is, instead of radioactive material that's bound to sugar, because lots of things in the body can have increased metabolism of sugar, but there is something where radioactive material can be bound to estrogen receptors. And so many of you may have heard estrogen receptor positivity or negativity for a tumor. So for tumors that have estrogen receptor positive, meaning that they would receive and actually kind of fuel themselves off of estrogen, we would have a similar study to this, but it's based on whether that estrogen would be tagged to the radioactive material. So an estrogen receptor positive malignancy or metastatic disease would then light up. So it's a really cool, when I say cool, it's a really useful state-of-the-art test that we have for patients that have estrogen receptor positive disease. And again, these are not only used for, is there cancer that's spread to the body, but is it responding to treatment? So oftentimes you could get these sequentially. So maybe has that lung nodule grown or has it decreased? Is it responding well to chemotherapy, or it has the cancer come back? So a lot of utility in these. We have a lot of different options. We even, MRIs if we're worried about a brain lesion. So lots of different options available.
Oh, thank you so much, Dr. Dufour. This was very informative. We appreciate you and your team supporting Carolina Breast Friends. And we hope that all of our listeners and followers will like and subscribe to Carolina Breast Friends YouTube channel. Thank you for being with us.